Living Life with Leora. I'm Leora Coca-Goldberg, and today's conversation is one I've been wanting to have for a long time, not just as a host, but as someone who has actually lived this. I'm joined today by three people who I trust completely on this topic. First, Dr. David Rankin, a board-certified plastic and reconstructive surgeon based in Jupiter, Florida. David specializes in breast explant surgery and reconstruction, performs over 500 explant procedures per year, and is known for his artistic and his precise approach. David, thank you so much for being here.
Thank you very much for having me.
And next to him, someone many of you know, and I have a personal history with, Dr. Randall Feingold. Randall is a board-certified plastic and reconstructive surgeon. He is the co-founder of New York Breast Reconstruction and Aesthetic Plastic Surgery. He sits on the American Society of Plastic Surgeons Breast Implant Illness Safety Work Group and has been honored many times by the American Cancer Society for his work. Randall was the surgeon who performed my own explant, breast lift, and fat grafting. So this conversation is personal for me. Thank you for being here again.
Thanks, Leora. Happy to be here.
And finally, I have to say the one and only, my special friend, Dee Hicks, a patient advocate who has walked alongside hundreds of women throughout their explant journeys for over a decade. Dee has spoken at FDA breast implant safety meeting and has been one of the loudest voices pushing for real informed consent in this space. Dee, thank you so much for being here.
So much for having me. I appreciate it.
You know, 5 years ago, almost nobody was talking about this. Today, 40,000 women a year, I think there is an increase of 10% annually in the US alone, are having their implants removed. That's not a trend. Obviously, it's a signal. I want to address this question to you, Dr. David Rankin. You've been doing this for such a long time. What have changed?
I think there's more of a recognition that breast implants are not lifetime devices, that they come with a series of possible complications. And, through a lot of grassroots efforts, women speaking with women, this is coming to light. It's coming to light in the medical community with other specialists recognizing what's going on here with breast implant illness, particularly, but for other reasons, too, women are choosing to have their implants removed as well.
You know, before we dive into the explant, I think that the terminology is probably not every woman knows what it means. Maybe it would be really good if we define it.
You want to take a shot at this one, Dee, or?
We refer to what is widely, spoken in the groups and through the women that come in, the on block, but really what we refer to it as is an intact capsulectomy. That is where the entire capsule comes out still surrounding the implant and with an explant. So that's imperative to be done, like to get a full healing.
Yes.
Yeah. And I think, Leora, when you're talking about, I think you're talking about defining what is breast implant illness, right? And how do we make that diagnosis as well? It's not really something that you can do a blood test or an X-ray or any type of examination to determine whether you have it. It's almost a diagnosis of exclusion where you've ruled everything else out, your health is suffering, and there's a series of things that we see in a lot of these women, symptom-wise and sign-wise, that we come up with the diagnosis.
Yes, and maybe Dr. Randall Feingold can answer this one. Since the numbers say 40,000 women a year, that are explanting, does that mean that we are having today a better education about breast implants and the risk and how to monitor them, and or maybe women are simply getting sicker? How do you explain that?
Well, I'm sure there is better education, but I have to give credit to the community of women that have had breast implants as being responsible for improving that education. Some of it was organic, through social media and finding other people that had their concerns or symptoms. Some of that was pressuring advocacy groups and the FDA to pay attention to this more, as well as to organize plastic surgery, the American Society of Plastic Surgeons. So people are more aware that there have been ongoing problems with breast implants in a variety of ways. And there's a trend to remove implants. There's also a trend towards smaller breasts in a society right about now. There's definitely a shift in perception, and a lot of things are happening at the same time.
Yes. Dee, I wanted to ask you because you talk to this woman before anyone else does. What are you hearing that surgeons don't usually get to hear?
I really feel like I hear more, I do a lot of listening to these women because, by the time they reach the goal of explant, they really have gone to every type of specialist, doctor, had every testing done and everything like that. But I think realistically being dismissed by doctors coming up to it because a lot of the tests come back, normal or within range, and these women clearly don't feel normal or, within range.
Yeah, you mentioned about tests, and I wanted to mention the screening, what typically women do. I remember when I had breast implant, I did every year ultrasound and mammography, and it came normal. And my question to Dr. Rankin is, when the results show your MRI looks fine, you have no issue, what if this sentence is sometimes wrong? And how often do you see normal result of screening with either ruptured implants and other responses?
Well, MRI is a good study to determine whether there is an implant ruptured, but it's not a good study to determine whether you're going to have systemic complications from your implants. That's true of ultrasound and mammography also. So those are good tests for their purpose, but not for defining someone with breast implant illness. I find in my practice that there's plenty of women, most of the women that do suffer from breast implant illness do not have ruptures. So just because you have a rupture diagnosed by one of these studies doesn't mean you're going to have any more severe symptoms than a woman without a rupture.
So
how long does implants actually last?
It really depends. Yeah, it really depends. Yeah, I mean,
in what shape?
Yeah, you can have a rupture after a year. You can have no rupture after 30 years. There's many reasons we believe why implants can rupture. Time, integrity of the shell, trauma, capsular contracture. So there's really no defining time of how long an implant is going to last.
Yeah. Are there any symptoms that women should know about that should never be ignored?
I mean, when it comes to breasts and breast health in general, I think any symptom, be it small or large, you need to look into because, there's always the possibility of breast cancers, which can be defined by lumps, changes in the breast, consistencies, the skin, the tissue. Really, when it comes to breast health, you just can't be too cautious.
So, I think that there is not enough attention to capsular contracture. And I looked into the percentage, and I think that maybe you can correct me if I'm wrong, 10% of women develop it at some point?
And with capsular contracture, there's a spectrum, and we label it a 1 to a 4, basically. And
yeah,
every woman does have some type of capsular contracture because we know the body forms a capsule around a foreign body to protect from the foreign body. And if that capsule contracts or distorts, that becomes capsular contracture. Anywhere from a 1, which is a normal soft breast, to a 4, which is changes in the visualization of the breast, distortion with pain. So all women do develop it. Severity, when it gets bad, those are the patients that need to seek care.
Yes. Is there any, can we say anything about inflammation in the body that is related to capsular contracture? And also, is there any relationship to ALCL, cancer of the capsule?
I don't think there's a direct correlation with capsular contracture and ALCL. I mean, ALCL is a cancer of the capsule and the pericapsular tissue. There's no real direct correlation with you've developed a capsular contracture, so your chances of ALCL or, other things are really more elevated. You do have a higher risk of rupture with capsular contracture. I do find patients in my practice seem to have higher levels of inflammation with capsular contractures also.
Yeah. So since we're talking about the symptoms, can we actually, for our viewers, and I'm sure that women that are walking around with breast implant at this moment, and I think there are maybe about 35 million women with breast implants. I mean, what are the breast implant illness constellation of symptoms? Let's mention the most common one.
Well, we know there's a lot. We know there's probably more than is stated on the FDA website for breast implant illness, and they've finally recognized it, thanks to advocates like Dee and other women and doctors that spoke at the FDA meetings. The ones that I see the most are fatigue, joint pain, a lot of skin rashes and skin problems, allergies that develop late in life out of nowhere, mast cell activation syndrome. Dee speaks with so many of these women. Do you have others that you can talk about, Dee, that you see all the time?
Like the hair loss, blurry vision, ringing in the ears, metallic taste in your mouth, thyroid issues, swollen lymph nodes that are typically, around the breastplate, those are very, very common. Those are, you really hit on most of them, but, to add, the hair loss, the blurry vision, ringing in the ears, metallic taste in your mouth. Fibromyalgia is huge, huge issue. Insomnia, depression, anxiety, all of those things. And I think that that's why a lot of the times it gets dismissed, or, the connection isn't made for a lot of women. So, when I speak to women, I don't tell anybody to explant. I really just kind of listen to them, kind of connect the dots for them where, their symptoms are, to, my own personal experience of what I went through when I had breast implant illness. I had such a severe case of it that, resolved completely, but, that's really the route I go.
Dee, I had, breast implant for 15 years, and it took me a while to decide to explant it. I was fearful of how I will look after, my explant surgery. What are you actually hearing from this woman? What are they afraid of the most, I would say?
It really goes back to how sick they are. For the most part, we got the implants for a reason, right? We had some insecurities, or, breastfed children, had loose skin, whatever the means is. So, aesthetic is huge. They're very scared of what they're going to look like. Many of these women have had them for a decade or more, and, it becomes part of their body. So the aesthetic thing, is really huge. But there's also those women that are like really sick, and they could care less what their aesthetics look like. They just want to feel better.
Yeah. So I want to address actually this question to Dr. Feingold and then to Dr. Rankin. What is actually a successful explant in your terms as a plastic surgeon?
Well, I think it goes to what the patient's goals are. As Dee said, if patients just want to feel healthier, they may be putting the cosmetic concerns as a second, concern. There are other patients that want to feel better but want to preserve breast aesthetics, and we have to do more for them than just intact capsulectomy. So you have to spend some time with your patient and determine what their symptoms are, what their goals are, in order to, really serve them the best way.
Dr. Rankin?
Yeah, I mean, I'm in agreement with Dr. Feingold. I think, ultimately the best success is doing a good explant and getting a good aesthetic outcome, because, even women that are sick, they're not so worried about the aesthetics, but once they explant, they start feeling great again, and their life changes. Well, they do become a little bit more focused on aesthetics. So you always want to create your best aesthetic result. And, it depends on each patient individually, how much breast tissue they have, how large are the implants, over the muscle, under the muscle. So there's a lot of factors. And I think listening to your patient, having a full discussion, and trying to determine goals of the outcome are important on the front end, so you can be really realistic with their outcome.
Yeah.
And with my practice coming out of both cosmetic and reconstructive breast surgery, I'm sensitive to the long-term aesthetic outcomes for our patients after we explant them. Sometimes they'll tie my hands and say, we're not doing any breast lifting. We're not doing any breast, fat grafting. And, I have my orders and I have to abide by, the patient's, instructions to me. But I do spend time with every patient to just review with them that just because the implant didn't work out doesn't mean we're giving up on the breast. And they may feel that it's of secondary concern, but I will go through that process of explaining why it's important to optimize breast aesthetics if it's not obvious to them. And sometimes I have to do a little convincing. And then I find that more patients will turn around and say, yeah, I do want to come out of this optimized, and they'll let me do more than just capsulectomy.
I think, Dee, you have a lot of what's called inside information. You're getting images. I mean, as a patient advocate, we have seen both on Facebook group. Some women post the result looking radiant and beautiful after explant. Other quietly disappear from the group, devastated, but what they have seen, after in the mirror. So what are your take on that one? Without mentioning names of plastic surgeon, obviously.
No,
That's funny, isn't it?
So, I do see a lot of the photographs and, I do help run a lot of the Facebook groups on social media, and I am privy to a lot of information that's not posted from,
Yes.
some of the patients. I will say aesthetically wise, a girl will post, oh my God, I look terrible, I look botched, and she's literally 4 days post-op. So, my best advice to all women is to allow your body time to heal. You had these implants most of the time for years. You're not gonna, miraculously look fantastic for the most part, immediately following. I mean, some of them really do, but some don't. And, so they may post a picture on the internet of like, oh my God, I'm botched. And then, they may message me 10 months down the road and say, oh my God, Dee, you were so right. Like I needed to give it time. But I wish those same girls would also update their post and go back and say, hey, I freaked out,
Mm-hmm. But I think that, like Dr. Rankin mentioned earlier, there is a lot of factor that comes into the result. But I would say also the skills and the expertise of the plastic surgeon.
Absolutely. Absolutely. I think experience, wholeheartedly makes a massive difference. I mean, I see it out there in the groups. I am so proud of these, newer upcoming surgeons who are, doing a proper explant, which is removing the implant and the entire scar tissue.
Mm-hmm.
And the aesthetics takes time. That's something that comes with, experience. And so with time and repetition and that, I think, that makes a huge difference on the aesthetic results for a lot of women.
So what else women should know, Dr. Randall Feingold, when it comes to muscle attachment and, that obviously we have seen women that were released from the surgery room after explant by some plastic surgeon that has not done proper muscle attachment.
Well, I think what you're touching on is that the process of breast implantation changes the breast. In some cases, the pectoralis muscle is cut, elevated off the rib cage, and an implant is placed underneath the muscle. That can thin the muscle, that can cause the muscle to ride up onto the chest.
Mm-hmm.
When you take the implant out, we ideally want to replace the muscle the way we were designed. Put it back on the chest wall, anchor it with sutures to other adjacent muscles or to the rib cage, and restore proper geometry. I think it's better for function. I think it's better for range of motion. Yeah. It relieves pain in patients that have had pec muscle spasm. It might prevent some fullness or a lump higher in the chest if the muscles retracted upward like a window shade. So, that's one aspect of, restoring normalcy. But when patients are concerned about the aesthetics after their implants are removed, it can go beyond that. Our breast tissue may thin as we get older. It may thin or attenuate from the pressure of an implant, pushing against it for years or decades.
Yeah.
And so women need to be counseled that when you take the implant out, the breast they see may not look like the breast that they remember when that implant was placed 20 years ago, whether it's age or hormones or these mechanical factors. So we do our best to optimize the breast,
Yeah.
but it might not ever be exactly the way it was.
Yeah, I think that as an exercise physiologist, I've really paid a lot of attention to the need to rehabilitate the rib cage. And we had prior conversation about the fact that the rib cage is a cartilage. In some places it's very soft, and when you have breast implant pushing against it for such a long time, it changes the shape and also the function of the rib cage. And I think it needs attention. It needs proper rehabilitation. I don't see in our community, Dee, tell me what you think, women talking about rehabilitation of that area after explanting.
No, I don't really hear a lot about that specific area. I do see, women are very, alarmed when sometimes it's a little concaved,
Yeah.
because those implants were sitting there exactly what you said, creating more of a pocket looking a little bit concave. But over time, that does fill out. I also see a lot of women with at the lower part of the breast that, they're like, oh, there's a lump there. And I had that for years, but I literally think it was like the implant just pushing down, creating more of a ridge right there, but I don't hear too much about that. Most of that stuff, corrects itself over time.
Yeah, I think though that there is, and correct me, I'm saying it to both of our plastic surgeon here, Feingold and Rankin, that the skin is of the back is being stretched by the implants, and then when you remove the implants, there is excess skin on the upper around the shoulder blades, and I've experienced it myself, and I had to really do a lot of workout to rehabilitate that area. And do you offer today for some woman that has a lot of excess skin or fat around that area some alteration during explant surgery?
Well, the implants do act as like tissue expanders, and the larger the implant, the more expansion of the tissue. And upon removal, you're going to have that loose skin.
Yeah.
Part of the breast lift is reducing and removing the extra skin. So it's a skin tightening as much as it is a breast lift.
Yeah.
That can pull some of the tissues from the axillary area and the areas around the breast as well. So you try your best through the lift to restore some of those areas.
That brings us to one of my favorite really topics, which is fat grafting. I think it's an amazing procedure. I've done it myself twice, and I got great result. Thank you, Dr. Feingold, for doing it. And so I want to talk a little bit about fat grafting restoration. What is your experience, Dr. Rankin, with fat grafting after explant?
It's something I do on a regular basis that I think it is a good technique. Me personally, I always wait about a year post-op because in my hands, I just feel like I get a better take of the fat, and I get a little nervous with putting fat into a immediately operated breast. But there's doctors that do it quicker than I do it. I think that the biggest downside can be fat retention and resorption of the fat afterward. So, and that's, we want to maximize how much basically survives, and we want to maximize our augmentation with the fat. But it's a great technology, a great technique. It's your tissue, it's not foreign, so your body doesn't react to it like it would a breast implant or another foreign body.
So, Dee, what is your experience with women who are having fat grafting?
I will say that most of the women, almost all the women that I speak to that are inquiring to explant with Dr. Rankin, I would say probably 95% plus inquire about it. Maybe 5 to 7% actually go back and do it. And I think that that's also, a little bit of the blessing of the grace period, right? Because we have you wait until the chest cavity is fully healed.
Yeah.
But what happens during that time of healing, the waiting period, these women tend to fall in love with their bodies all over again. They're like, do I really want to go under the knife for aesthetic reasons? It really gives them time to properly make the decision, a proper decision, not in fear of when they're explanting, like, oh my God, what am I going to look like? You know what I mean? So the good part about that waiting period is I see a lot of women just really fall in love with their bodies. They haven't seen that girl in, 10, 20 years, sometimes 30 even, they really kind of fall in love with themselves, especially after they get a breast lift and, a lot of the excess skin is removed, they just kind of feel so beautiful and confident in their own skin. But I do see women, do go back and get it, and it's an excellent tool to add, some enhancements to the breast that are not toxic like the breast implants are.
Yeah. And, I think that many years ago, I would say maybe 4 years ago, 3 years ago, when we talked on, on this Facebook group about fat grafting, there was a very negative reaction from women, and I see it gradually going away as it becomes more mainstream.
Yeah.
Maybe we can touch a little bit, Dr. Rangel or Dr. Rankin or Dr. Feingold, on fat necrosis. How often does it appear, and what is your experience?
I do not see it very often. I think that the ladies that have fat necrosis are from getting a fat graft with, pushing the envelope too much and getting too many cc's put in.
Mm-hmm.
I'm a little bit, with everything that I do, I'm more on the conservative side. And I think if you have a conservative approach, your chances of developing these complications, particularly fat necrosis, go significantly down. I think fat necrosis is it's the lack of blood supply being obtained through your body to the fat cells, and if you just add too many, your body lacks the ability to create that blood supply. What's your take, Dr. Feingold?
Well, I agree with everything you just said. First of all, I don't see as many people inquiring about it as you do, but I think I promote it to more of my patients than you do, conversely. But my background using fat grafting in cases of young girls with congenital asymmetries of the breast, and in women that want small volume augmentations without implants, and supplementing breast lift patients that don't want implants, maybe makes me more aggressive about using it, because I use it for a lot of different indications in my practice, not just backfilling explanted patients. But I definitely agree, you need blood supply. You cannot overfill a breast. You'll overwhelm its capacitance, and all of it will die if you put too much in and pass a certain threshold. And I think there are technical barriers, to successful fat grafting. And, I harvest fat, through ultrasonic liposuction. I only use very small cannulas. There are patients in whom I'll add growth factors back from blood or from fat centrifuging and processing to increase percentage take. So I think that there's its own art and science to doing fat grafting. And it may be that early experience with fat grafting just wasn't that successful and created hesitancy in the community, and health concerns about it. And that's, going away slowly and surely as more practitioners become more dedicated to, perfecting their fat grafting results. But I never push it on patients, and we simply let them know these are options for aesthetic optimization of your explant. Could be lift, it could be fat graft, it could be both, but we don't pressure patients, and we only want to do what they're comfortable doing. It's a great tool, and I think we'll see more, sort of expansion of that science in the coming years.
Say that I agree with Dr. Feingold wholeheartedly. I have been in this community for, about 11 years now. And, you know, initially, back in 2016, 2017, we would see some fat grafting, and we did in the group see a lot of complications. That's why there was a lot of negative talk about doing fat grafting because of what we were seeing. And those were things that were never posted in groups or anything like that. But I think we have come so far and evolved, and people have really fine-tuned the craft, and it's gotten um, much more beneficial to women because of the surgeons that are doing it, that have fine-tuned the craft. But I do wholeheartedly agree. I think they've come a long way with the fat grafting techniques for sure.
Yes, Dee, I agree with you, because I think like 4 years ago, we would see women that had, and they will post, and I was also part of some fat transfer group where they went to certain doctor that injected 500 cc, even more of fat cells, and obviously this women are the one who later on had necrosis.
Yep. Yes. I've seen and experienced it back in the day. You know, I used to run the group that now has over 200,000. I ran that group for, 4 or 5 years. So there's
Yeah,
so much that you don't see posted, that,
exactly.
but my knowledge has also expanded with working with Dr. Rankin and having a better understanding and watching it evolve like it has, because these doctors have really come a long way with the fat grafting. And, I always make a joke about Dr. Rankin. I call him Captain Cautious. He is conservative, but it's with good reason. And, his results definitely show that.
Yeah, I think that it's better to be safe than just to do something that later on can haunt you. I
Mhm.
know, actually, you know what I saw when on my way here? I shouldn't say it because I was watching a little Instagram, but that was on a red light. I saw an ad of a plastic surgeon who talks about a lunch break. You can have fat grafting in a lunch break. And he was mentioning alloclay, what it is, how it differs from fat grafting that we know so far.
Well, alloclay, it's fairly new, particularly for breast enhancement. It is basically morsellized cadaver fat. Um, I believe it's cadaver, but it's human fat, morsellized. I think it's too early and for me to start utilizing it for a number of reasons. Number one, part of the process of explanting is removing foreign material. And often in my practice, I'll be asked to remove meshes like stratus, which is from pig collagen, and alloderm, which is from human cadaver collagen. Um, so now to put it in to augment the breast, I'm going to be on the sidelines on this one for a while until it's studied a little bit more. It also comes in very small aliquots, which are extraordinarily expensive right now as well. So there is a financial component as well. But
Mm-hmm.
I just think for me, it's just too early to tell. I just don't want to get into a situation where you're injecting this and the
Yeah.
patient then has complications. You can't just go in and remove it. So I'm just going to sit this one out for a while until there's further studies.
Mm-hmm. Dr.
Well,
Feingold?
you're not going to find further studies right now. I just did a deep dive on this subject because I spoke on this topic at the ASPS Patient Safety Committee meeting a week ago.
Mm.
And it is cadaver derived, it's terminally sterilized,
Oh, wow.
it's delivered warm, it sits on the shelf for 6 to 12 months, is what they claim the shelf life is.
Yeah.
And there are, what we call like level 5, level 6 evidence, which is physician observations that when you inject it, it retains volume for a year, maybe a year and a half, maybe longer. What we don't have is, the histologies, the biopsies of it at 3 months, 6 months, 9 months, 12 months to tell us what's in there down the road. We know it's not going to come back to life. So it was dead tissue. Does the cellular extracellular matrix induce your body to grow more of its own fat cells in? It's possible. There's a little bit of animal data on that, and it would be great if that's true. But its biggest utility is in hip dips and in augmentation of soft tissue in the GLP-1 population, I think, right now.
That's
And
it.
while it is being used by some of the early adopters in the breast for augmentation and assisting with breast reconstruction, I agree with Dr. Rankin. It's a bit early. The breast has special concerns. We need imaging and vigilance to detect breast cancers. And if we don't know what the product is going to evolve into, maybe it'll all just be fat necrosis down the road, and how is it going to change the imaging? I just don't think we want to take chances and cause problems for another generation of women because this wasn't extensively studied, because as a tissue transplant, it's not a synthetic or a pharmaceutical, so it doesn't require FDA pre-market approval testing. It's handled like any other tissue transplant, like
Mm-hmm.
alloderm is, or rib graft, or things that are used in orthopedic reconstructions. So its utilization is way ahead of its understanding right now.
I'm really interested to know how GLP-1 medication is affecting tissue quality and fat graft survival after, explanting.
You have another hour?
Okay. Is it affecting or not?
GLP-1 is the fat burner, and um, for those of us that have done plastic surgery on weight loss patients, we know that they have to stop their GLP-1s a little bit of time before surgery because of anesthetic risks, but there's more appreciation that GLP-1 patients need to enhance their protein intake to heal from surgery properly and perhaps postpone restarting it for several weeks afterwards. We don't have perfect protocols about that yet.
Yeah. Dee, I want to ask you, what's your take on that? Why is it that women are still learning about implants risk from Facebook instead of their doctors?
I think it'll continue to be that way, actually. There are a lot of great doctors out there, that are doing augmentations that are giving proper informed consent, but there's tons that are not. It's still very much sought as like the women, they're trusting social media over the doctors in a lot of cases because we are the data, so to speak. We have absolutely um, been in the trenches forever. And when a woman, say I speak to a woman and she went and did a couple of consultations with other doctors and she's complaining about symptoms that she has, and this doctor tells her, stay off social media, there's no proof to this. I mean, there's so much of that that's still out there. And on the flip side of it, there's a lot of referrals that we get from primary cares, chiropractors, all kinds of medical professionals that say, hey, I think it's your implants. But there's a lot of the plastic surgeons are still in massive denial that breast implants cause problems. I mean, it's a foreign body made up of over 40 heavy metals, chemicals, carcinogens placed above the heart, lungs, and there's repercussions to that. It doesn't come symptom free for everybody.
Exactly. I would say for everybody is a key word also because we know that not every woman will develop the symptoms or some kind of autoimmune response. But we also know, and correct me if I'm wrong, that over the years, as you proceed and you're getting to 10 years, 11 years, 12 years, you see more and more maybe autoimmune response to the breast implants.
Yeah, I mean, I think education is key, and there's been a push by the American Board of Plastic Surgery for doctors to present their possible augmentation patients with, full list of the risks, the benefits. Now speaking about breast implant illness as a possibility as well, and if a patient is well informed as an adult, then they have a choice to make. And I think that a lot of women, even understanding some of the risks, will still choose to have an implant, and some of those women do just fine and have no problems whatsoever, and others move on to developing problems and symptoms. And to at least be aware that if your health is declining, thinking, hey, this might be my implant is very important, because then you can pursue that path to healing as opposed to being gaslit by other doctors that say it's in your head, or it's not the implant causing the problem.
Yeah. Since we're talking about this, who is what do you know about insurance and dedicated codes, and how can we help women that wants to explant, from your experience, to get some reimbursement from the insurance company?
I am definitely seeing a shift in the insurance providers giving something back for implant removal. It's a breast lift is usually never covered under it, but I do think our second trip to the FDA, that was, our main focus was trying to get them to recognize breast implant illness as medically recognized so that we can get insurance codes for it. But I think for women, most women are able to get some, not most, but a fair amount are starting to be able to get some sort of reimbursement from their insurance companies because they have a paper trail.
Exactly.
Meaning by the time I explanted, I had 54 symptoms on the day of my explant surgery. And when I woke up, 45 of the 54 were gone completely. But I had been to oncologists, infectious disease, endocrinologists. I'd had every test under the sun, all the blood work, everything done. So, most women have that paper trail to say, hey, and now that, through our advocacy efforts, we were able to get them to put breast implant illness on the FDA website, and it does list some of the symptoms. And I think being able to correlate that these symptoms came from my breast implants, it is helping women. It's important to get, a detailed copy of your operative report, photographs or a video of your surgery so that you can submit it with your claim independently. And, a lot of the times, the women are getting something. It almost always gets rejected initially.
Yeah.
And then but that's just how the insurance kind of works, I think. So then they submit again or again and again. But so I am seeing more success now than say I did 8 years ago. There's been a huge jump in, the insurance because, if you think about it, if you have insurance and you're going all the money and all the testing and whatever it costs my insurance company leading up to my explant, had they just explanted, they would have saved thousands of dollars so to me, it's like no brainer, but they do it a little differently than I do.
You're being too logical about it. The insurance companies always don't always see it that way. I can tell you the New York experience. Well, first of all, for my patient population that may have come from breast cancer and mastectomies, their care is always covered under insurance. So if they have problems with capsules, ruptures, systemic symptoms, they're going to get their capsulectomy, explant, revisions, lifts, fat grafting covered by insurance. But in my cosmetic population, we're still having a tough time with insurance coverage unless we're taking out, one of those now recalled macro textured implants that have an association with ALCL. Now, carrier after carrier have amended their policies, allowing for insurance coverage for that particular diagnosis, but that's not necessarily BII. So sometimes grade 4 contractures with ruptures will get covered, even in the absence of systemic symptoms, more for the local stuff. But we help our patients out as best as we can. We give them their intraoperative photos, we give them their operative reports, and whatever success they can get, we're happy to help them.
Saying all of that, I want to end with a very sort of emotional question because we are all here parents. And I want to ask each of you, if your daughter told you tomorrow that she wants to have breast implants, what would you tell her?
Yeah. Go ahead.
So, I have a daughter. She is 33 years old, and probably about 2 years after I explanted, she was like, "Oh, I'm going to get breast implants." And in my case, which I'm sure would be much different than Dr. Rankin's or say Dr. Feingold's, but I was like, "Are you crazy? Did you see that they almost just killed me? Like, don't do it." But also they're going to make their own decisions. Do you know what I'm saying? But it's about being properly informed. But I actually experienced that. She didn't end up getting them, but and sometimes daughters like to push buttons. So I don't know if it was a little button pushing on top of it, but she definitely inquired to me that she wanted to get breast augmentation. And I told her I love her, but like they almost killed me, so I'm not on board.
Yeah. Well,
yeah, my daughters are 16 and 15. So, and they see what daddy does for a living and they kind of live it with me. So, I would be a little bit shocked if they went down that road, but if it happens, obviously I'll educate them and hopefully they can be persuaded not to go down that route.
David, I sort of moved almost full time to Miami, and I'm just shocked, like, how many women have breast implants here. It's just incredible. It's sort of normalized, it's like younger women, older women, grandmother, and I look at them and I'm like, how come they're okay? I mean, but it's really, you see it here, I think more than in New York, or maybe in New York they're more covered, I don't know, but here it's really obvious.
Well, if you look at the statistics, the average implant in New York is going to be a smaller CC volume than Miami or California. So
okay.
it's actually it's geographic for sure.
What about Dr. Feingold? What's your answer to that if your daughter told you she wanted breast implants?
My 31-year-old daughter, who now has a 3-month-old child, is definitely not thinking in that direction.
Mazal tov, by the way.
And never actually, thought in that direction in her single years or perhaps before she started being a mommy. I can't tell you what the future, would hold for her, but, I think I would tell her the things that are sensible that I repeat to so many patients. First, it's really not about the size of the breast, at least in my opinion. I think breasts are beautiful at all sizes. When I see a Ralph Lauren model walking on the runway in a summer dress or an evening gown without a bra, and they're all tall with, barely an A cup, I still think that's a beautiful, sexy woman. And that femininity comes from, just having breast at all and confidence, you can't teach confidence, unfortunately, but, there are things I have to tell patients that come from the patient decision checklist that's been mandated now that the manufacturers want you to sign before someone puts a breast implant in. And it goes to the local complications in the breast like contracture and rupture and systemic, complications, which, I guess I'll call sort of the biologic activity that an implant can have in the body, So I would feel really compelled to go through all of that. And, I talk about that, with so many patients. It's not unique that I would apply it only to my daughter. I believe that these are, the realities of it. And plastic surgeons just have to do a better job now than they did, in decades past when they might have glossed over some of those, details or told patients that, you'll be good for life. And we know that's not true.
Well, I want to end, first of all, thank you so much, David, Randall, and Dee. Thank you genuinely. This conversation is one I wish. Oh, go ahead, Dee.
No, I just said thank you so much.
Oh.
And I really enjoyed this.
Thank you. And I want to say that this conversation is one I wish I existed in 2007, when I did my first breast augmentation. To everyone who is listening, if you have implants or if you're thinking about getting them or explanting them, please be sure to ask, to ask around and find someone that you trust. I really hope, genuinely hope that today gave you some real answers, and the confidence to have this conversation with your own doctor. And thank you again, everyone.
Thank you.
Thank you for having us. I also want to say a special thanks to David Rankin because, many years ago, when I became more and more aware of explantation process, he was very gracious and allowed me to visit him down in Florida. And, I have a lot of respect for someone who's dedicated their practice to a particular craft. And like Dee said, he's, conservative and he's really competent at what he does. And, I just want to say thank you for all the good work you've done for so many women.
Yeah, thank you very much. That really means a lot to me. Appreciate it.
So nice, Dr. Feingold.